Okay, so I'm going to refer to the first case, case A, vulvar onset, 39-year-old woman. I've given her a spouse with a young family, children ages 3 years and 14 years. So firstly, what I'd like to point out is communication is fundamental to relationships. So we're looking at family relationships, but also personal and professional. Self-expression and connecting with others can be a very key ingredient to the quality of life. It's also necessary in order to direct one's care. And so from all of this, I think we're going to be doing this theme among us, early intervention is crucial. And one thing could be helps with the intimacy and the connection is voice banking. So while the voice is still intact, to bank that voice, and it can be used later on in invasive devices. So then also another thing then to be looking at is family coping, support for children and spouse. So are there any behavior difficulties with the children? The spouse overburdened? Who can they talk to? Do the children confide in friends? All these kind of things to consider, which would go into what I was talking earlier about the caregiver resources. So assessing what's needed. Finances, I'm just going to touch on what potential things that you might want to be looking at. At the end of my slides, I have websites of the most common areas that I would be referring people to. But in this particular instance, we would be looking at compassionate care benefits, potentially for the spouse if he's working. And the website gives you details on the criteria for that. Given that the patient is under 65, at some point you may be looking at a drug program. If they're involved in the CCC and have professional involvement there, then they can be assigned a drug card. And then there's also the Trillium drug program, depending on your financial means. And then you'd also consider eligibility for financial assistance and certain disability pensions. And that would depend on the circumstances here. We've just got the bare bones of this case, so we don't know if this woman worked at some point and had to stop working because of her disability. But that would be something that you would want to be considering. And what I have emphasized here, that if that is the case, you want to do that as soon as possible, applying for this Canada Pension Disability. And another consideration is disability tax credit. So other things to consider, which is very important in the social aspects of ALS, is that there can be huge changes in roles and identity. One obvious thing is spouse becoming caregiver. There can be changes in responsibilities due to the changes in the capability of the person with ALS. For the person with ALS, there's a loss of physical ability, and they can also in communication in the vulvar situation, and this can profoundly change one's personal identity, how they see themselves. An area, intimacy and sexuality, and this is an area that doesn't get addressed. And we've had feedback that indicates it's an area of concern for couples that they find themselves struggling with alone. And some of this comes from that it can be difficult to adjust to new perceptions of oneself and one's spouse as being disabled. And it also can be difficult for the caregiver to assume both caregiving and romantic roles. But this is a sensitive topic to cover. It can be an uncomfortable topic for everyone to talk about, including the healthcare workers at times. And for some couples, it's simply a taboo topic, come from an era that you just don't talk about these things. And that needs to be respected. So case B. Limb onset, 66-year-old man living on his own. Communication, I want to add here, is should also be considered for the same reasons as outlined in scenario A. However, in this case, written communication, including computer access, may need to be addressed. Social supports, emotional and physical. It's important to get the extent of the social network. Given the recent retirement, he may feel even more isolated, lost, and bored, so emotional support could be crucial. One important thing to consider is eventually he may not be able to live alone due to limited healthcare resources. He could experience a lot of grief associated with this and have difficulty in making alternative plans. If he is very determined to live on his own as long as possible, a pattern may emerge of postponing acceptance of equipment and services that may indicate a decline in his condition and self-sufficiency, such as a walker or personal care. Some patients react by deciding not to accept possible life-sustaining interventions, such as the BiPAP or a PEG. Also want to add there's a potential for depression given the amount of life-changing events, retirement, and terminal diagnosis. There's a few things that I just want to quickly add that are, I think, are important issues that could apply to both scenarios. Suicide thoughts and behavior. Some people with ALS question their purpose and reasons to continue living, given the drastic change in circumstances of their lives and the significant loss of control. This can be another isolating factor. It may be difficult for those in their immediate circle to listen to this or understand and appreciate where they're coming from. Having these feelings validated and accepted can be critical. It is also important for healthcare professionals to keep one another informed of potential risk for suicide. So here are my websites, and I just wanted to add quickly the closing remarks. Just some recent conversations in clinic have added a theme of loneliness. And one person eloquently talked about how you can be in a crowded room and still be lonely. And still having many services and professionals, you can still feel alone. And so I hope by listing at least the issues and offering them to consider will help in attempting to bridge the gap of